So our work really tried to address an increasingly relevant issue for which many hematologic malignancy patients are increasingly facing. So bispecific antibodies, or basically BiTE cell therapy, represent a new and important but emerging direction within the space of blood cancers, particularly hematologic malignancies. And their use is rapidly increasing. This T-cell modulatory therapy has demonstrated significant efficacy in multiple landmark early and phase 3 level cancer trials. And because of this, multiple therapies were granted FDA approval, even within the US within the last 12 months, and even within this year alone. However, unfortunately, we appreciated with other novel therapies, particularly therapies like CAR T-cell therapy, immune checkpoint inhibitors, and other therapies, that really there were potential cardiac or heart manifestations for which many of us did not truly appreciate relatively early on in the experience, and certainly in the phase of, phase 1, 2, and even in some cases, phase 3 trials. So within this, and in light of multiple discussions with a number of our hematologic malignancy colleagues, we set out to really better elucidate and understand truly the cardiovascular profile of these therapies, given their rapid emergence and the relative absence and really essentially absence of cardiovascular related data on their actual safety risk in patients. So within this, we leveraged the FAERS, or the FDA Adverse Events Reporting data set, to understand the actual disproportionality of the reporting of adverse events in relation to BiTE cell therapies, with a particular focus on cardiovascular events. Within this, we looked at a number of cardiovascular events, or elements such as heart failure, arrhythmias, myocarditis, pericarditis, vasculitis, and even sudden cardiac death. We also explore the relationship of these adverse events to other AEs seen with these therapies, including elements like cytokine release syndrome, neurotoxicity, and really other toxicities like infections. And importantly, within this, we tried to adjust for potentially relevant factors that were available to us. The data set itself is limited in part on its ability to fully dissect relations between baseline, say, demographic characteristics, but elements such as age, gender, and disease status are readily available. So within this, we had calculated an adjusted reporting odds ratio, or basically this disproportionality signaling ratio of potential adverse events. We also looked at the relevance of these events to the likelihood of mortality in these patients, just to better understand the magnitude of relevance for these events, whether or not they were just more nuisance events or really things that impact patients and their potential outcomes. So within that, and within the FAERS data set, we had appreciated that there were nearly 1,200 cases of adverse events reported to the FDA data set with BiTE cell therapies. And amongst these, roughly about 10 to 15% involved cardiovascular events. Many of these events included elements such as hypotension, thromboembolic disease, heart failure, bleeding, and tachyarrhythmias. And less commonly reported were things like myocarditis, pericarditis, and sudden cardiac death. But within all of this, we did note in further analyses that like BiTE cell therapies as a whole, as a class, really associated with an increase in the reporting of hypotension, shock, as far as adverse events. And then specifically, Blinatumomab, as well as other therapies, and additionally appear to associate with some increase in overall signal of potential myocarditis, as well as some other, it associated with an increase in DIC, my apologies, but Teclistamab associated with an increase in myocarditis. And even as a whole, we weighed all therapies together as we added 2 or 3 additional, even more recently approved FDA therapies and updated analysis that were performed just before the actual meeting, and were at least included in our poster presentation. There was a clear signal for an increase in myocarditis with these therapies. Importantly, the development of any cardiovascular AE, specifically myocarditis and some of the arrhythmias, as well as heart failure, did appear to associate with an increase in the likelihood of potential mortality. And then importantly, there was not a clear relationship between these events and in the development of other adverse events, particularly CRS, cytokine release syndrome, neurotoxicity, and infection. And specifically, that included events such as the myocarditis and heart failure, which were not always truly associated with CRS, and a potentially surprising finding for which we identified. Now, putting this all together, really, where does that really leave us? Well, really in the first really large-scale post-marketing surveillance analysis, it is clear that bispecific antibodies may associate with at least some element of significant cardiovascular risk, and that the development of these risks portend or at least associate with significant potential morbidity and mortality. And signals such as myocarditis and heart failure deserve further investigation in more longitudinal studies.